session where we talked about endpoints of resuscitation, and I talked about lactate. And I haven't changed my mind between Monday and Wednesday, so there will be some overlap in this presentation. But at the end, I will focus more on how to do it at the bedside. Now, why is lactate interesting? It's part of definitions, and so we come back to the first speaker. If it's a part of a definition, you should measure it. But there's also something in lactate that can help you to, let's say, be concerned or less concerned or not concerned at all in your patient. It has specific prognostic elements, and I will try to dissect them a little bit. If you look at this slide, you have patient with septic shock, so non-responsive to fluid administration, remain hypotensive, and need a vasopressor to increase their blood pressure to a minimum level. If you then look at those patients, and you look at patients with or without an increased lactate, and here Glenn and Anders use 2.5, you can see there is a huge difference in mortality. And so a patient with septic shock without lactate, so vasopressors, but no lactate, is something different than a patient on a vasopressor with lactate, 90% versus 57%. This is a study from 2011. This is a more recent reanalysis of the ARISE database, and they basically did the same. They looked at patients that did not respond to fluids with an increase in blood pressure and remained hypotensive. And they looked at patients with a blood lactate of 4 or more without specific hypotension. If you then look at the 90-day mortality that they analyzed in this study, you see a large group of patients, isolated refractory hypotension, 850 patients, and isolated hyperlactatemia. So this is sepsis with a very high lactate level, 4.0 millimoles per liter. That's almost 500 patients. But the difference in mortality is significant. It's almost twice as high in the patient with only lactate and no hypotension. And that's basically reflecting what Glenn and Anders also found. If you have hypotension but no lactate, that's something different than when you have increased lactate. So that's one. You should be more concerned in your sepsis patient when there is lactate, absolutely. What about the changes in lactate? Because when we start to resuscitate in a patient with increased lactate, we always look for decreases in lactate. Jean-Louis Vincent did a review of, at that time, all studies available that at least measured 2 lactate levels. And so you could make a decision about whether the lactate remained the same or decreased. And he found 96 studies. And these 96 studies basically covered every patient, every, let's say, diagnostic category we have in the ICU. General population, ICU, general surgical, post-cardiac surgery, trauma patients, sepsis, cardiac arrest, respiratory failure, let's say our common ICU patients that we see on a daily basis. And what he found in this study, if your second lactate level is lower than your first lactate level, the chances of survival are much better than when your first lactate level, your second is the same as the first, or when it even increases. And so it's right, the general feeling that we have, that when you see a decrease in lactate, the patient is doing better than when there is no change or even an increase, is confirmed by this review of 96 studies available in the literature. So how come there is this, let's say, predictability of lactate over hypotension, for instance? And why is it so consistent in all these patient groups? Well, that's because there is more in lactate than circulation. And we wrote this review, Glenn Hernandez and Rinaldo Palomo, last year. And And we talked about the pitfalls of lactate clearance. Now, normally we say we measure one lactate, we measure a second lactate, and the difference is clearance. That's not completely correct because clearance is something different, but that's how we use it in clinical practice. You take two levels and the difference between the two we call clearance. If you look at it that way, then lactate adds much more information than only this is shock or no shock or resolvement of shock, because lactate has many different origins. So there is production, there is clearance, and so if the clearance is impaired, then you will have higher levels, and clearance doesn't necessarily need to be impaired related to circulatory dysfunction. There can be liver dysfunction, and of course, liver dysfunction has its own prognostic value. And so we came up with 10 pitfalls in lactate clearance, but also stressed, as you can see in the cartoon, the different roles lactate has in a sick patient beyond just circulation. Now, what happens if you use lactate to guide treatment? So if the general feeling is okay, if lactate decreases, the patient is doing better, would it make sense to try to decrease lactate by therapy? Now, we know from earlier studies that you can easily decrease lactate with dichloroacetate. That doesn't affect outcome. If you increase the metabolism, that doesn't make any difference. And so what we did together with Tim Janssen, a PhD student in Erasmus, what we did some years ago in a multi-center study, we said, okay, let's assume that in the early hours of your sick patient, and these were patients with increased lactate levels, where we thought it was related to circulatory dysfunction. So this is not septic shock. It's frequently quoted and referenced as a septic shock study, but that was a large subgroup in this study, but it was every patient with a lactate above 3 where we thought there was a circulatory problem. And we said, okay, try to optimize the circulation, and optimizing circulation is try to optimize the balance between the oxygen requirement of the tissues and the delivery of oxygen to the tissues. And that should result in a decrease in lactate, and we said 20% probably makes clinical sense. It was consensus. There are no real data on what makes sense and what doesn't make sense. Given the logistics in the 4 centers, we could not increase or decrease the time between measurement 1 and measurement 2 below 2 hours. In many centers, it was impossible to do it very frequently. And so we chose 2 hours. So the endpoint of resuscitation was every 2 hours, you measure your second level, and it should be 20% lower than your previous level. Or lactate is normal. And the entry was, okay, how do we define the circulatory dysfunction that you can have in these patients? Well, either it's a convective problem that should be related to a low SCVO2, or it is a distributive problem, and then you could have a high SCVO2. And so that's why we discriminated between low SCVO2 and high. And in the high group, we said that's a distribution problem, so let's try a vasodilator. And in the convective problem, we said, well, you should manipulate DO2. And so cardiac output, saturation, and hemoglobin. And don't forget to manipulate oxygen demand. So a patient fighting to get some air in, a patient with a lot of pain, be aggressive on treating pain and put the patient on a ventilator. And this whole package was done for 8 hours because we said circulatory failure in your patient should not last for more than 8 hours. Then you should have resolved the problem. And what we found is that it improved outcome if you correct for baseline abnormalities. Together with Wanyi Gu from China, we did a meta-analysis of all the studies available that did the same thing with some variation, and we focused on sepsis. So we took the patients in Tim Janssen's study that fulfilled sepsis criteria, did the meta-analysis and found that indeed, if you in sepsis patient target lactate, it's associated with an improved outcome. Now, were we right that in the early hours of sepsis and septic shock, the lactate is more circulatory based than, for instance, liver dysfunction or metabolism or increased glucose metabolism, for instance? And so what we did together, Glenn and Anders and I, in patients that survived septic shock, we said, if it's true that in the early hours it's more circulation and later on it is metabolism or inadequate treatment of sepsis or whatever, then there should be a difference between the early hours where lactate normalizes and later on. And so what we looked at is normalization of lactate. There's some kind of INR of lactate. And as you can see in this slide, this is the first 6 hours. That's the data we have. Remember, all these patients are survivors. And what we looked at is normalization of lactate. And as you can appreciate, this curve is almost the same as other perfusion parameters. So this is the delta PCO2. And this is capillary refill time. This is a peripheral perfusion parameter. This is a more central perfusion parameter related to cardiac output. And as you can appreciate, the rapid normalization of lactate in these first 6 hours coincided with a rapid normalization of perfusion parameters. So it seems valid, at least in this group of survivors, that indeed in the early hours of septic shock, your lactate and your lactate signal reflects adequacy of perfusion. We tested that a little bit further when we looked at patients with lactate with or without these perfusion abnormalities. And so we said, what's a perfusion abnormality that we use in clinical practice? That's SEVO2, the delta PCO2, and capillary refill time. And so we said, if you have lactate with any of these perfusion parameters being abnormal, is there a difference? So does lactate with hypoperfusion parameters or without make a difference in patient outcome? And although not all the difference were statistically significant, it was not a very huge group of patients, you can appreciate that the patient in a hypoperfusion context having an increased lactate did worse than patients that have normal perfusion parameters and increased lactate. And so it seems that if you have hypoperfusion and you're in the early phase of septic shock and you correct the perfusion, your lactate dramatically decreases much more rapidly than, for instance, in the later phase. If you look at 6 to 24 hours, the normalization rate is much lower than in the early hours. The same for the delta PCO2 and the same for capillary refill time. And 50% of these surviving patients still had increased lactate. So they did not have hypoperfusion anymore. That was corrected. But they still had a problem with either lactate production or lactate clearance. And so in this period, lactate is telling you something different than please give volume to correct your lactates, what I call reflex medicine. A resident measures lactate, they see an increase, and that means half a liter of fluids. If after half a liter the lactate is not normal, another half a liter goes in. That may be appropriate in the early hours, but definitely not, probably not in these hours. And so we have these two mixed signals. We have, like, if you use lactate for 8 hours, it may improve outcome. And we have this element of perfusion parameters, and especially peripheral perfusion parameters that are very simple to collect. And so we said, well, we have to compare the two. And so that's why we did the Andromeda shock study that was published in the JAMA early this year. And what we compared is we do the Tim Janssen approach. So you target lactate, it should decrease every 2 hours by 20% or should normalize. You do it for maximum 8 hours, or you use capillary refill time, a very simple measure, as Iwan also alluded to, very simple method at the bedside. We used 3 seconds as a normal cutoff point. And so the goal of treatment is to normalize your capillary refill time ASAP. And once you have your capillary refill time less than 3 seconds, you stop resuscitating. If you're still unhappy with blood pressure, then you increase your norepinephrine, and the same for lactate. If you keep having this 20% decrease, that means that's the end of the resuscitation efforts. If you look at mortality, this is the mortality in the lactate group, this is the mortality in the peripheral perfusion group. It seems a very constant difference between the two, but it didn't reach statistical significance. It was a p-value of 0.06. And given let's say the way we describe outcome in these studies, or let's say the effect of these studies, we had to conclude that this was a negative study. And that was the conclusion of the JAMA paper. And immediately a storm of responses came from colleagues by Twitter and Facebook, and they said, are you kidding? This is a clinically relevant finding. It may be a p-value of 0.06, but this is clinically very relevant. Why don't you do a Bayesian analysis? And Zampiri from Brazil was, let's say, kind enough to do this somewhat complicated analysis. And this has just been accepted in the Blue Journal for publication. And so what you do in this Bayesian analysis is something different. You take a different approach, like, would this be likely beneficial to my patient? And so what you do is you make a very optimistic prior, and so your pre-test probability is, yes, this will have a significant effect on outcome and improve outcome. And in the pessimistic prior, what we did is we said, well, I mean, you can think that you have a reduction in mortality, but basically it will double your chances of dying. And so this is the optimistic prior. It's what we found in the study, 0.67. And the pessimistic one is, okay, the mortality will actually increase if you use capillary refill time. If you then look at the chances that the capillary refill time will still benefit your patient, then even if you're extremely pessimistic, there still is a 93% chance that the patient will benefit from your intervention. And so that's a somewhat more clinical approach to, should I use capillary refill time or not? And given these numbers, I would say, yes, I think you could use capillary refill time to resuscitate your patient. So if you want to combine all of this together into how to do it at the bedside, I made this, let's say, flow diagram. So the first thing you need to do, and I think you need to do it with everything, with blood pressure and almost everything that you measure, is you need to create context. So you measure a lactate, and the lactate is abnormal. The first thing you need to do is not, let's give 500 ml of fluids, but what's the context here? Is there a likelihood that this lactate is due to something that has nothing to do with tissue perfusion? For instance, if you have a diabetic patient with metformin, or you have an HIV patient taking a viral antagonist, there's a chance, or vitamin deficiency, there's a reasonable chance that there is no circulatory dysfunction. And so if you start treating the patient with fluid, that won't help. And so if you have, for instance, the most appropriate one is seizures that we see quite regular. Every seizure should have a lactate, but none of the seizures require fluids or dobutamine. And so if you think, well, no, this is not really circulatory dysfunction, this is something else, think about what something else could be, and then, of course, act accordingly. If you think, well, no, it's not very likely that something else than tissue hypoxia or tissue hypoperfusion is a cause, so probably there is some circulatory dysfunction. Given the studies that we have done now, my first, let's say, action would be look at peripheral circulation. If the patient is warm and so capillary refill time is normal, or you just do a simple subjective test, you put your hand on the patient, or whatever means you use. If the periphery is normal, and then you measure your SVO2, SCVO2, and SCVO2 is also normal, that's weird. Then you have increased lactate, you think it's a perfusion deficit, I think what we know now, a measurement of delta PCO2 is appropriate. You can be warm, you can have a normal SCVO2 and still have an abnormal delta PCO2. You're getting into the small numbers, but it's possible. If also your delta PCO2 is normal, then basically every perfusion parameter that we can use at the bedside tells you, you may think this is a perfusion abnormality, but there are no data. There is nothing to support you. Then please rethink. Did I make the right decision? Did I make the right diagnosis? Is this really tissue hypoperfusion, or did I miss something? If the delta PCO2 is abnormal, then you have an indication there is a decreased flow, and then optimized flow with either fluids or dobutamine or milrinone or whatever you want to use. This should be normalized, and so less than 6. And this should result, if you're still right that the lactate is a perfusion problem, should result in a decrease in lactate. And then you wait and see, because now everything is normal, and then you wait. If nothing happens and lactate doesn't change, then again, rethink. Did I make the right diagnosis? Did I have the right idea? And if you think, I cannot think of anything else, then remeasure in 1 or 2 hours and see if the change in lactate took more time than you thought. If you have the suspicion that this is a perfusion problem, and your peripheral perfusion and or your SCVO2 is abnormal, then it's quite easy. You correct the perfusion abnormality. And so you do whatever you think is best for your patient, fluids, dobutamine, or whatever you want to use to increase tissue perfusion. In the Netherlands, we love nitroglycerin. It took me some time, but finally in Columbia University in New York, now we sometimes use nitroglycerin as well. So whatever you think will optimize tissue perfusion, do it. It should correct your abnormal SCVO2. It should correct your abnormal peripheral perfusion. And as a result, the lactate should fall. If it falls, then wait. So your parameters are again all normal. Wait and see what happens. If you increase the perfusion, so SCVO2 and peripheral perfusion, and nothing happens to lactate, then again measure your delta PCO2. It could be that you didn't do enough. And so measure delta PCO2 again. If delta PCO2 is normal, rethink. If delta PCO2 is abnormal, you have to redo your optimization of blood flow. If lactate does increase, you have to rethink again and remeasure again. And the complete scheme is like this. And so the first thing you need to do is create context and then use all the perfusion parameters we have to optimize. So increase lactate or increasing lactate levels should make you nervous, at least in some cases. In conclusion, lactate is a strong predictor of outcome. Therapeutic interventions aim to decrease lactate, improve outcome, are associated with improved outcome. Using lactate to guide therapy is complicated by all the other factors that influence lactate levels. In the early phase, it seemed that it's much more related to perfusion than to other problems. And it may even be that capillary refill time or peripheral perfusion-guided resuscitation may be superior to lactate, which underscores the importance of improving perfusion in early septic shock. Thank you very much.